Mark, out of curiosity, do you continue the single agent or do you continue the combination?
I continue whatever I can, and as you pointed out, you give cisplatin, eventually you're going to get hearing problems or you're going to get renal problems. If you give a taxane, you're going to get neuropathy, and yes, it's stopping it at the right time. I mean, Heather's point is absolutely
You've gone
correct.
beyond 4 to 6 cycles of the platinum.
Absolutely. Actually, I turned your paper, your and Stitchcom's paper, Mark, you converted me. When you put all these trials together about duration of therapy, number of cycles, every one of them, people have better survival getting more.
But Mark, you stop at 4. 4 cycles for the conventional, at least for the platinum compound.
Right, at least for the platinum compounds or a taxane. And you know, we do have a couple of switch drug maintenance approaches. And you know, I do think, I agree with Ben, I think maintenance is an option. One of the issues I think with maintenance therapy is that, you know, for the majority of our patients, remember I'll point out the median age is 71. These people have comorbidities, there are lots of issues. It's hard for me to think about continuous treatment. And all of us have the experience where we say, well, we could do maintenance, but we could take a break. Many patients want a break, some time off of therapy. And I think, you know, as Mark said, you got to be a doc. You got to follow them closely. I always say to my patients, my job is to know when your tumor's getting worse before you know it's getting worse. And so we can talk about how to do that. We don't have a lot of studies in terms of surveillance protocols and stuff like that. But I think time off therapy is very therapeutic for many patients. And therefore, you know, the whole kind of continuous treatment forever in an incurable disease, let's face it, in the oncogenic driver population, we're still dealing with a median survival of 10 to 12 months. And it's tough to kind of keep people on treatment and the cost of toxicity.
So at least in your population, it's a continuing negotiation.
Yes,
every time
absolutely.
you get a scan. And have you resorted to alternative strategies, going for, say, 4 cycles and then giving a break for 6 to 8 weeks?
I say to my patients, we're going to do, I mean, you're kind of on autopilot for 4 cycles, unless a disaster happens. And then we're going to look at your scans, and we're going to rediscuss the issue about what to do now. And I tell them right up front, sometimes the right answer is to take a break. Sometimes the right answer is to continue.
You introduce the concept of maintenance at the get-go, not when it comes
I
up.
do, because I agree with Mark there.
The case.
I think so. I agree with everything that Mark was saying. I think that discussion has to begin at the beginning of treatment, right. And then you have to integrate the art of medicine with the science of medicine. And patients routinely come to me, and when I tell them that we're going to do maintenance, they ask, well, is this going to be for the rest of my life? And I think the answer is, we don't know.
Yeah. Right.
We'll probably not. We'll take a treatment break. I think you really have to tailor your decision based on patient preference, motivation, and performance status, and if they're deriving a benefit from the drug. So I think each patient is different, and I think we shouldn't be wedded to just one paradigm when it comes to maintenance.
So individualization is key. What about insurance issues? Have any of you run into scenarios where you've gotten pushback from the patient's insurer saying either no maintenance, or if you're considering the combination, which granted is not standard, one or the other?
We've not, you know, if we have insurance issues, it's really upfront in deciding what to do. Once you're on therapy, I think I have others that have said that, you know, that they don't come back and question your, you know, medical judgment in terms of what you're doing for the 6th cycle, in my experience.
That's not been an issue really with the ECOG trial per se.
No, it hasn't been. I mean, the continuation maintenance tends to never be an issue. The switch maintenance can sometimes come up, but I haven't personally had a problem with that.
What about cumulative toxicities? I mean, PEM is a generally safe drug, but you do see some unusual problems. Mark, any comments?
Yeah, there are a couple of unusual toxicities. Again, I give a lot of PEM and BEV together, so it's hard for me to just pull out which one caused the problem.
As maintenance or as second line?
It is continuing initial therapy.
Okay.
Make the best choice up front and stick with the winner. What you see is, I'll call it an edema syndrome. And to be honest with you, there's nothing you can do when that syndrome starts but to stop both drugs. I think that's the answer. But people say, you know, they notice generally lower extremity edema, and it becomes, and it just progresses. Cutting one drug out, lowering the doses doesn't seem to help.
I've seen a fair amount of epiphora, which is hyperlacrimation, and also some degree of fatigue, which is not really captured by the data in the Paramount.
The eye problems in my patients happen up front. Those people that have the eye, they've had it all along, and we aggressively try to deal with that with the various eye drops. I mean, it's counterintuitive that the problem causing tearing is that their eyes are too dry. I mean, it's really tough to get that across. And also, the plugging of the tear ducts, which can be
I've
done.
seen that.
A lot of ophthalmologists are involved here. They really try to aggressively treat these patients. And again, it's the whole package. If the patient says it's worth it, then it's worth it. If not, you're done.
So I haven't had too many problems with the hyperlacrimation. I see that more with the docetaxel than I have with the pemetrexed or especially with the bevacizumab, where we get into issues, the counts can sometimes start to have a little bit more of a lag in coming back.
And you've seen some renal toxicity?
And I've seen some renal toxicity in some of my patients. It's not a high percentage. For some of them, it's something that's happened around cycles 3 and 4, and others it's been out 4 months or longer. And then the fatigue also can be a bit of a problem, and then also have seen the edema. And what I have done with a number of patients, when we get out kind of 4, 5, 6 months, we kind of spread out to a 4-week schedule as opposed to an every 3-week schedule. For patients in that setting who've gotten out that far, there's something about their disease where it is perhaps slower growing, at least sensitive to the treatment, where I feel comfortable spreading that interval. Is there data? No, but that's
And as
what
both Marks have pointed out, this is incurable disease,
Right.
and we really have to balance the patient's quality of life and their life events down the pike and schedule of treatment.
I actually do 4 to 6 weeks with Bev. It has a very long half-life. If you're at steady state, does 6 versus 4 weeks really make a difference? So I give patients that choice because they got stuff going on.
The patient tells you, they say,
Yeah.
by the way, I have 2 great weeks and the bad week. Can we make it another week? And
Yeah,
the
that's
answer is
right.
yes.
That's exactly
Talk
right.
to the patient.
So it's quite clear 10 years ago this was barely on our radar. Now, at least for this panel, it's part of the
this panel.
standard. Well, I don't think we were routinely giving it before 2000. And now it's become, again, part of the standard therapeutic paradigm. As Ben's pointed out, this is the majority of patients. Most patients, unfortunately, do not have a driver mutation or a fusion protein. And there are still some skeptics out there. I suppose in a perfect world, the 5508 trial would have a control arm with immediate crossover perhaps to the combination at the time of progression, but that trial would probably be undoable in the US.
It would be difficult.
Yeah.